Welcome everybody, and many thanks to you all for the contribution to this virtual meeting on the ModiLite treatment of thyroid nodules with laser ablation. Professor Ralph Tufano is the co-chairman. He doesn't need any particular presentation thanks to his excellent professionality and personality in the scientific world. But let me spend just 2 words to introduce him. He's Charles Cummings Professor, Director of Head and Neck and Endocrine Surgery Department in the Johns Hopkins University in Baltimore, Maryland. He is a recognized world authority on the management of thyroid cancer, thyroid nodules, benign thyroid disease, and parathyroid disease. So please, Ralph, would you start with your introduction to the webinar? And thank you again.
Yes, Stefano, thank you so much. This is a wonderful event, and I thank you for letting us know about this effort and using lasers to treat thyroid nodules. As you know, we've recently begun our efforts in the United States to perform radiofrequency ablation of thyroid nodules. We're often a little late to the game in these things. And so with your enthusiasm, especially with RFA and being a pioneer in radiofrequency ablation of thyroid nodules, your encouragement to consider laser ablation as well really piqued our interests. And so I have a wonderful team of people that I work with here in the United States. Later on, you'll get to meet Catherine Sinclair and Tim Huber, and they are absolutely wonderful and helping to spearhead these efforts in the United States with regard to the ablation technologies, the interventional technologies for ablation of thyroid nodules. So we're really excited about this. We want to learn from you as well, and we want to see how we could apply this here in the United States and elsewhere. You know, I know there are many international guests today, and we're so thankful to have them, and I know they're really excited. So without further ado, again, thank you for this opportunity. And I'm going to take a brief moment to introduce you. So of course, Dr. Spezia is wonderful and well-renowned as well. He is humble, but he's the chief of endocrine and ultrasound-guided surgery in the operative unit at Ospedale del Mare in Naples, Italy. And also he has a PhD, the University of Turin. And his expertise are robotic assisted endocrine surgery and minimally invasive techniques. And he is at the Reference Regional Center, both in Naples and also in Rome. So he has 2 offices. He is very, very well known in all of Italy, of course, but especially throughout the world. And he will be talking to us today on introduction on the role of percutaneous thermal ablation in the treatment of thyroid nodules in the USA. And so I'm really looking forward to this. This is an opportunity for me to learn more than I have to speak. This is great. So please take it away, Stefano.
Okay, thank you for your wonderful presentation, introducing me to this argumentation on laser ablation of thyroid nodules. I think that it's very important to enlarge our panorama, our view on the minimally invasive treatments. So this could be a good opportunity for all endocrinologists and endocrine surgeons. So let me start with my presentation. That's okay. Well, this presentation will move from introduction to the basic principles of the laser ablation, the presentation of the ModiLite planning procedure, setting and technique for benign nodules, and updates for malignancy. Follow-up will discuss the conclusions, and THM will end the session. Thyroid nodules are very common in general population. The majority of them may be followed, but they require treatment when become symptomatic. Surgery still represents the standard of care for the steadily growing nodules and patient concern. But as you all know, surgery could be affected by severe complications, even if executed in centers with high volume of surgical cases. Moreover, the role of lobectomy versus total thyroidectomy is actually widely debated for the risk of reintervention in case of unexpected malignancies in the risk of hypothyroidism or for the increase in postoperative complications. An important underestimated issue is the QOL, influenced by the hormone replacement therapy, the post-thyroidectomy syndrome, and the presence of the scar, the major concern for women. Thus, we are moving now towards the tailored thyroid treatments with minimally invasive procedure, mainly for symptomatic benign nodules. The first experiences date back to the end of the 90s in Europe, and the first two published papers with Professor Pacella, unfortunately passed away last year, my great friend, represent two milestones on the feasibility of percutaneous laser ablation on the thyroid tissue and on the first results in the treatment of autonomous functioning thyroid nodules and compressive benign nodule. So what's our goal? The aesthetic improvement and functional recovery. Nodule shrinks to an asymptomatic size with restoring of cosmetics and physiology of the neck. So patients return to an excellent quality of life, restoring a normal life immediately for physical activity and social relations as well. Minimal invasive thyroid treatments, why not? Elderly patient at high risk for multiple organ morbidity or a young lady refusing surgery and having a scar in the neck. These cases can be treated to ameliorate symptoms and for aesthetic improvement. According to the last ETA guidelines, the European Thyroid Association, percutaneous laser ablation and radiofrequency ablation are recommended as the first-line thermal ablative treatments and recently introduced into clinical practice as a valid alternative treatment for autonomous functioning thyroid nodules as well. Now I'll show you some technical aspects on laser thermal ablation. How does laser work? Laser is a focused beam of light energy, usually generated by a diode laser, a multi-source diode laser with 1064 nanometer wavelength that is delivered to an optical fiber that is inserted into the target tissue. The laser operates with an output power that can range from 3 to 5 watts, but we usually use 3 watts only, and a flat tip quartz optical fiber with 0.3 millimeter in diameter. Laser ablation may be performed either under US guidance with a dedicated device or assistance, that means with a freehand technique. Experimental studies have demonstrated that, the elementary necrosis produced by laser is composed of an area of big coagulative necrosis that surrounds the central area of carbonization and cavitation that is due to the vaporization of tissue that is very close to the fiber tip. And all the lesion is surrounded by a ring of simple edema. The volume of necrosis is predictable because once we will decide the power in watts and delivering 1,800 joule, we exactly will know, you see in this diagram, we know how much will be the volume of the necrotic tissue. But if we increase the energy, the necrosis enlargement is inefficient because the cavitation area increases without affecting the necrosis of the treated area in a linear way. Thus, how to furthermore increase the volume? We can increase the watts. You see here, increasing the watts, we enlarge the volume of necrosis. Or better, we will insert a second fiber at 10 millimeters, 1 centimeter distance from each other, merging the single spots of necrosis, and finally pull the fibers back in order to have an enlargement in the volume of necrosis. Here you see this guide that is applied to the probe, in which we insert the needle guide and the fiber in the sheets of the needle guides. The preoperative assessment checklist is the same as for all the terminal ablative treatments: 2 fine needle aspiration cytologies, the evaluation of the ultrasound parameters, solid, mixed, spongiform, and so on, the symptoms and the aesthetic score, the lab test. We don't need fine needle aspiration cytology for autonomous functioning thyroid nodules, according to the latest guidelines. The use of MRI and PET and CT is advisable for malignancies to have an extended and detailed description of the lesions to be treated. The procedure is done with a dedicated operating setting. In this case, we are in my operative room, my hospital, and we use a Nico laser system with the laser that is integrated in the US equipment. This equipment is available in Italy. As you see in this slide, this is all the material we use usually during the procedure, and the patient that wear a goggle to protect his retina from damage deriving from unexpected use of the laser beam. In the United States is available the EcoLaser Evo, that is the laser equipment you see here, and the ECI interface, the laser smart interface, a technology that allows the visualization of the fiber trajectory through the sheet of a dedicated needle guide mounted on the probe. The ECI is linked to the US machine in order to transmit the information. On his monitor, this is the probe with the guide that we use with the fiber. In this way, the operator plans the treatment to easily reach and treat tissue even in hard to reach anatomical sites. The guidance system, providing different angle of insertion, allows to better match the needle insertion with the shape and position of the nodule, more or less superficial in the neck, varying the angle of introduction. Sorry. The ECI interface visualize on the dedicated monitor everything that was planned. So the position of the probe, the insertion angle, the number and distance of the needles, the needle tip position, the energy dose, the need for pullback, number, distance, pullback. Please note that this blue line that you see here is not the volume of necrosis, but it represents the safety area that I will explain in the next slide. The optical fiber is introduced through the sheet of each needle with its tip extended 5 millimeters out of the needle tip. In direct contact with the target thyroid tissue, the fiber tip under ultrasound guidance is positioned at a safe distance at least of 8-10 millimeters from each other, and laterally, and 1.5 centimeter frontally. So we have a distance of safety of 1 centimeter laterally and 1.5 centimeter frontally from the tip versus the vital structures of the neck: blood vessels, recurrent laryngeal nerve, trachea, and esophagus. When multiple applicators are applied, should be separated by a space of at least 0.8 millimeter. This is the distance between the needle or the fiber, and placed next to each other on the same plane to set the simultaneous real-time control of the two optical fibers, as in this case. The vocal cord movement should be assessed before and after the procedure with the fiber optic laryngeal examination or with transcutaneous laryngeal ultrasound, as you can see in this personal case. Local anesthesia is not needed, but if you prefer, it should be done with the lidocaine in the pericapsular space under US monitoring. As you can see here, under US monitoring, we introduce the needle and we create a fluid collection between the posterior wall of the step muscles and the capsule, the anterior capsule of the thyroid gland. We can decide, according to the shape and volume of the nodule, to insert 1 or 2 fibers with a fixed power protocol setting at 3 watts. Professor Papini suggests in his paper to apply 800 joule per milliliter for nodules up to 10 milliliter and above 500 to 600 joule per milliliter. The lighting time is about 10 minutes for a single illumination to deliver 500 joule per milliliter more. That means about 1,200 and 1,800 joule per fiber and for single illumination. This protocol requires a delivery of energy greater or equal to 500 joule per milliliter. In other words, if we have a nodule of 10 milliliter, we need 5,000 joule to deliver. And in order to ensure satisfactory results in terms of shrinkage, avoiding long-term regrowth of the nodule. This is my personal case. I show you here. This is a large nodule with the internodular vascular signal. We accurately follow the planned program with 2 insertion of fibers. The hyperechoic area is expression of the necrosis, and the pullback technique allows us to enlarge the final volume of necrosis, the hyperechogenicity at the end of the treatment, and see also the disappearance of the color Doppler signals. Resuming all, this is the checklist of the ModiLite treatment: venous line, cardiomonitoring, conscious sedation, no local anesthesia, laser protective goggles, probe cover and guide, Chiba needle, skin disinfection, sterile drapes, the choice of the angle and lines, the treatment planning, the insertion guidelines, checking the tip position and the insertion of the fibers. Then we start the laser till the desired energy output has been delivered, then stop, the pullback if required, and start the laser again, the extraction of the needle and the fiber together, not separated. And finally, we apply a transparent medication, Tegaderm, and then an ice pack. We use this transparent medication because we can check by ultrasound examination the neck of the patient without removing any bandage. Clinical monitoring after the procedure, follow up at 1, 3, 6, and 12 months with lab tests, postoperative study for percutaneous ablation with the laryngoscopy, fiber optic or transcutaneous laryngoscopy. At the end of the procedure, we have to check for any symptoms of discomfort, and ultrasound evaluation is mandatory before discharge, and the patient should be informed on potential complications the first week, such as fever, swelling, abnormal pain in the neck, and so on. I'll show you now a recent case I've recently treated. Is a young lady. The first treatment, this treatment was done in October 24 of the last year. The basal volume was 37 milliliters, a mixed nodule with a large fluid collection inside. We aspirated large fluid collection before starting with the laser. We used 2 fibers, 3 watts, pull back at 1 centimeter with a total amount of energy delivered in that was about 18,000 joule. At 1 month follow-up, the volume was 20.9 milliliter. So we had a shrinkage of the nodule 56% less. And at 3 months, the volume was 15.2 milliliter. So the shrinkage was about 60% less. And this is the aesthetical final result of this young lady that you see before and after 3 months from the laser ablation. And autonomous functioning thyroid nodules can be treated. We don't need fine needle aspiration cytology. The laser treatment is indicated for nodules up to 10.2 milliliter. And in the Gambe study, laser ablation is effective in nodules up to 15 milliliter, and the percentage of reduction is the best parameter predicting a normalization of TSH. Laser ablation is indicated with the treatment of metastases and recurrences. Here is shown a node metastasis after thyroidectomy and lymphectomy for papillary cancer. This is my personal case. And is shown a node in the fourth right level close to the vagus and to the common carotid artery and the jugular vein. The node was less than 1 centimeter. We applied hydrodissection to expand the space with this fluid collection, the space between the vessel, the vagus, and the node in order to reach the lymph node in a safe way. Now you see the introduction of the needle guide and then the laser fiber in the sheath of the needles that was pointed on the superficial aspect of the node. And this is the final aspect of the node that was treated. A reliable evaluation of the real size of the ablated area is achieved a few hours after treatment with the intravenous injection of Sonoview, or maybe less precisely with the use of color or power Doppler, or by the use of high-performance vascular softwares of the ultrasound top-quality machines, as in this personal case I show you. Finally, in this slide, we compare traditional surgery lobectomy with robotic-assisted thyroid lobectomy and ModiLite. As you can see, we don't need general anesthesia. The procedure is about 30 minutes. We don't need hospital stay because the patient is discharged after 2 hours. We have no scar in the neck, no signs in the neck, and the patient doesn't need hormone replacing therapy. Thus, what are the strengths of laser ablation? Laser is a precise and tissue-sensitive technique. Laser got FDA approval on 2018. It's a safe procedure because of low delivered energy that is predictable and accurately easy to plan, less invasive in respect with the other thermoablative techniques because we use a 21-gauge needle that is less than 1 millimeter, and we have no need for moving shot technique and doesn't affect the dangerous triangle. It's an easy procedure, easy to learn and easy to execute because we can use a single needle or a double fiber introduction along the longer axis in a longitudinal plane using the applicator on the probe. Is feasible because this technique is available for pacemakers or defibrillator holders and for pregnant women. Well, you see that you know that bipolar RFA is not yet approved for this treatment. Feedback is immediate for the patient. We don't need, usually we don't need local anesthesia, but if you need, please apply the pericapsular lidocaine injection. The learning curve is short, is less operator dependent, because you know that RFA implies a lot of improvisation due to a great experience of the operator, while laser ablation is predictable and the standard techniques programmable. The multidisciplinarity of the technique, because we can use this technique for urologists, for surgeons, and for radiology interventional radiologists in so many applications. The laser ablation technique so could be the technique of choice in patients with compressive benigns, but also for recurrences and metastases for malignancies. Some tips and tricks. Necrotic effects are predictable and easy to plan. Please strictly apply the program model, because damage of the nerve is very rare but possible. The technique will reduce complication and improve results. It's possible to use the freehand technique, but only for very skilled operators. It's possible to reach anatomical structure not easy to treat with the freehand technique, using the hydro dissection when indicated. Voice change and pain should be evaluated for stopping the procedure. So evaluate vocal cord movement, also with the use of transcutaneous laryngeal examination, and change the position of the needle or reduce the power output. If anesthesia is needed, use the pericapsular lidocaine infiltration. And this is my THM. In my personal opinion, it would be stupid to fight a war between laser and RFA. The war should be between surgery and alternatives to surgery altogether. Too many patients are still sent to surgery because the operator are not even aware of non-invasive alternatives. The #1 goal of this talk is to inform doctors about these alternatives. Okay, I will start with my last. Okay, this is my last slide, and I invite you to the next meeting on the ATA virtual meeting that will be held on February 19, 2021, where I will present laser ablative technique again. Thank you so much for your attention.
That was a fantastic presentation, Stefano. I think that you're right. The most important aspect is information and education. And we really don't know what we don't know. And so this is important to inform people so they get interested and they can do further research and investigation. I think a few things, if we haven't, I think we have a little bit of time for some questions, but I would like to ask you a few questions. I agree with you that there are many patients who are submitted for surgery who just don't need surgery. And I think that we need to have strict indications for those that should definitely have surgery, and then those that would be appropriate for these interventional techniques, either laser or RFA, as you said. And so further defining that and making that very clear is very important, that these should be first-line treatments. Because also what I think we found with RFA and laser is that it certainly doesn't preclude surgery if necessary down the line. So why not try that approach first, right, if you can? I think one of the things I would ask you to comment on is the need for the conscious sedation. As you know, here for us in the United States, we're pushing the radiofrequency ablation in the office, and we are just using that pericapsular injection of the lidocaine, much like you do when you use RFA, I'm sure, in your clinic. Pros and cons of this: do you think that the process is a little bit more involved and maybe a little more costly if you use laser? Or what are your thoughts about the economics of it, the financial aspects?
Okay, about the financial aspects, I can see that both techniques are similar. Obviously, I refer to my experience in Italy. So we have the total reimbursement by our health system in the hospital or in clinics. And we are, for the cost of the needle of RFA and the fibers of laser, we are about on the same cost of 1,200 euros. I know that in the USA, this is different because the patient pay out of pocket this technique because there is not yet a CPT for the reimbursement of this procedure.
Correct.
And I know that we are working on this issue to solve as soon as possible this problem, to get the insurances to pay for these techniques. And this helps us to spread them all over. About the matter of the conscious sedation, well, I don't use it often, but rarely when the patient presents to my observation is very anxious, is very concerned, or is healthy. My anesthesiologist prefer to give her a conscious sedation that is very light sedation. But usually the technique is absolutely painless. If you accurately follow the protocol, so you use the safety area, you are not in contact with the capsule of the thyroid gland that is, as you know, very rich in sensitive fibers, so transmit the pain. So the blue line that I showed you in the slides,
Right,
in the
right.
slides, okay, must be close but not on the capsule, okay, and not deep in the posterior wall, posterior capsule, in order to prevent pain. But pay attention, be careful, because this is an important alarm signal, because if the patient say that he has pain, it means that we are very close to the capsule, and so very close to the muscle or to the deep layers of the neck. So it's very important that the patient can cooperate with us during the procedure. So he must be awake, he must cooperate with us during the procedure, because if he has pain, it means that we are very close to the capsule. So it's a signal for us. So we have to just a little bit move the tip of the needle, or just a little bit reduce the output power. Okay.
Thank you. No, that's very important. When I think about RFA, and you mentioned this, versus laser, let's just talk about that a little bit. RFA requires a lot of skill and an understanding of the moving shot technique. It's very operator dependent. Would you say that the laser is a little more standardized and a little bit more, I think, formal in a way that it's less maybe operator dependent, so that once you have the needles in place and you have everything set, you're in it's a little easier to do? What are your thoughts? So what are the differences, you think, technique wise?
Thank you for this question, because it's very important to transmit the right advice to our colleagues. So in my opinion, laser is more easy to perform. The only skill that we ask to the operator to start this procedure is that is skilled with fine needle aspiration cytology, because we introduced the needle along the short axis of the probe. All the length of the needle during the procedure, And we have, with the standard protocol, that means not the free-hand technique, but the standard protocol with the device applied to the probe, it's very easy to introduce the needle guide and follow it on the monitor of the ECI, that is the laser interface, and introduce the needle guide, introduce the fiber inside it, and control everything during the procedure. The only thing that the operator have to do during the procedure is to stay firm with the probe on the neck of the patient. Nothing else, because the laser produce the deliver of energy during a time that can vary from 10 to 20 minutes, and you have not to move the fiber, or at least you have to retract the fiber of 0.5, 1 or 1.5 centimeter, and it depends from the volume that you want to achieve by the laser treatment.
And when you are
So
doing
very
this,
easy to understand.
Yeah,
it's very easy to follow and to teach also.
When you are doing this, and then, you know, forgive me because I only have a familiarity with RFA, so I'm very interested in hearing and seeing more. So this is exciting. You know, with RFA, we continue to use the ultrasound and our Doppler, color Doppler, to try to visualize maybe areas that we didn't get completely elated. And sometimes it's a little hard to reconcile if we have all of the area that we want to ablate. Your feedback here, is it easier to get a sense of the ablation pattern, as you said? And I know you had talked about using contrast enhancement with SonoView. We don't have that here in the United States. Maybe I'll ask Tim Huber to discuss this a little later, but we don't usually use this anyway. And so do you think it's a little easier to understand how effective you are immediately and what your expected volume reduction will be? What are your thoughts?
Yes, my thought is that at the end of the procedure, the hyperechoic area that is similar to what is produced after RFA, the hyperechogenicity of the nodule is the effect of the necrosis. Then we can turn on color Doppler and power Doppler examination, but I think that now with the US machine of top level, we can apply the HD Doppler and B-flow technique to get a visualization of the necrotic area, as well the absence of vascularity in the nodule, better than only with the use of a color Doppler and power Doppler. So at the end of the procedure, we can have a predictable evaluation of the efficacy of the procedure with these methods.
Just one last thing. I'm going to get a chat question from Bruno Scotti, and he says that obviously he understands that based on the initial volume, there will be different rates of success, but what is the success rate with usually a single session in a patient that you deem very good for laser ablation? And that's the first question. And then the second is, do you need two people for this procedure, or is it just one person who can do this, the needle and the laser, etc.? That is his question. Two questions.
Okay, the second one is easier. We need one doctor and one nurse to perform the procedure. For the first question, sorry.
The volume reduction.
The problem of the volume reduction. Well, we according to the literature, we think that a satisfactory results after the procedure is of 60% at 1 year. So if we don't reach 50% after 1 year, this is a good predictor factor of the unsuccessful procedure. And if we don't reach this shrinkage at 1 year, we can reperform one more session, but we have also to better study the tissue around the necrotic area in order to avoid the presence of not revealed malignancy all around the necrosis of the thyroid nodule.
Thank you, Stefano. I don't want to delay because I know Professor Papini is up speaking next, and I know you would like to introduce him. So he is scheduled for the 10:10 slot, and let's stay on time, please. So go ahead.
Thank you, Ralph. Well, Professor Enrico Papini, my great friend, is the scientific director of the Regina Apostolorum Hospital in Albano, Rome, and a consultant of endocrinologist in the same institution. He's a pioneer of ultrasound assessment of the thyroid gland and for thyroid interventional procedure. So please, Enrico, can you start with your presentation?
Well, just a moment. I try not to mess up. Well, dear friends, I'm so glad to be here with you because this is an arrival point. I had the opportunity to present in several steps at the United States congresses the evolution of the ablative techniques. And so I am excited seeing that now United States that are always at the frontier in science and medicine are starting with these new procedures. Well, we know, and in its concise but very comprehensive presentation, Stefano explained us that we have a still superfluous surgery for benign thyroid lesion. And this is very funny because we have ethanol ablation since 30 years, dermablation with laser since 20 years. And now we have also a quite robust scientific evidence that is increasing, we could say, day by day. And well, this was the first publication of the feasibility study on thermoablation. In 2000, we were aware that the use of ethanol ablation for solid lesion was not the best approach, and the use of physical energy could be by far more precise and provide a well predictable area of damage. And these studies were confirmed during the following years for all the different kind of thermal ablation procedures. I can remember here, just passing, which are the key publications on thyroid nodules that are benign, on metastatic lymph nodes, and on thyroid microcarcinoma. And so my presentation will go through three different moments: the past, the present, that is, the current evidence and the indications to treatment, and what is the near future. And certainly, after the feasibility studies, the first study that demonstrated on a well-defined protocol that was followed by different centers in a randomized prospective controlled trial was performed in 2014 and demonstrated that a single treatment of solid thyroid nodules provided a decrease that was rather steady from 12 to 36 months, while, as expected, the control group had a slow but progressive increase. And what was most important, all 4 centers operating with the same equipment and the same modalities had fairly similar results. That is, the technique was highly usable from different operators. And the other major issue was, yes, this technique is effective in decreasing the volume of the lesions, but what is the risk of major and minor complications? And this was a retrospective study, very large retrospective study that involved the great majority of the centers operating with laser in Italy, and was published in 2015. And as you can see, we had about 800 treatments. In the vast majority of cases, it was a single treatment. And besides the nodule volume reduction that was quite satisfactory as a mean, we had a very low rate of minor complications and of major complications that were cases of transient, temporary voice changes. And again, from Claudio and myself, we had the opportunity of comparing in 2017 the results of laser and radiofrequency, again, a large number of patients, again, 8 centers operating with laser and radiofrequency. And as you can see, we had a rather similar and satisfactory volume reduction, but we had a lower rate of complications with laser. And all the studies will demonstrate that the efficacy of laser is, well, always associated with a substantial safety. And I cite this study for 2 reasons. The first one is that Hervé Montpessin is a good friend of mine and collaborated with me for the European Thyroid Association guidelines. He works in the American hospital in Paris. And Adrien Benamour and Hervé Montpessin performed a good series of cases and consecutively using either radiofrequency or laser ablation. And the clinical symptoms and the volume decreased significantly in the 2 groups. And again, the only cases of recurrent laryngeal nerve palsy were reported in the radiofrequency group. What about the hyperfunctioning nodules? Certainly they are less frequent than solid cold nodules, and we have a very effective non-surgical modality of treatment, that is radioiodine. But anyway, if we want to treat them without irradiation, we can see that a single session of laser is effective and safe in toxic nodules with a volume that is under 50 milliliters. And for nodules of larger volume, we can use these, especially in very large nodules that are hyperfunctioning. This is a study of our group, 2014, combining laser ablation for inducing a massive destruction of the nodule, followed by radioiodine after 1 month. And it was demonstrated that the control of hyperthyroidism and the rapidity of the decrease of the volume of the nodule were much faster with this combined treatment. And so now we are at the present. What the guideline tells us about this treatment? The first guideline that considered treatment with laser or radiofrequency for thyroid nodules was the guideline of the American Association of Clinical Endocrinologists that in 2016 stated that laser or radiofrequency could be considered for the treatment of complex or solid nodules that become symptomatic and cause cosmetic concern. And we had the need of a more comprehensive information for all the physicians that are facing the problem of thyroid lesions. And so I had the privilege to chair in 2019 this guideline of the European Thyroid Association that was published last year, very recently. And now we have a clear guideline for our clinical practice. Of course, not only for the use of laser, but in general for the use of minimally invasive techniques. And of course, for pure or mostly cystic lesions, ethanol ablation remain the first-line treatment. And thermoablation should be used only if the cystic lesions, sometimes it happens with a hemorrhagic cyst that can relapse rapidly after ethanol ablation, or for those cystic lesions that are mainly complex nodules, that is with a solid component that could remain symptomatic. In that case, the use of laser is really very effective and should be considered. And what about solid nodules? Certainly, as Stefano told us before, thermoablation is not a substitute for surgery. But now we have a portfolio of technique for the different conditions that, of course, are conditioned by several factors: age, patient's values, risk, and of course, the location and size of the lesion. And of course, it's obvious that thermoablation is strongly recommended against for lesions that are stable and asymptomatic. And what about the different techniques? This is a usual question at the end of every presentation. What is better? And I had the opportunity in our department of testing all the possible methodologies for thermal ablation: laser, radiofrequency, microwaves, and HIFU. And on this basis, personal experience, on the basis of the experience of the panelists, and on the basis of the evidence present in literature, We recommended laser and radiofrequency as the first-line thermoablation treatment. Microwave is certainly a powerful methodology. It's extremely rapid, but the major problem is precisely in its power and in the great difficulty of precisely determining the area of tissue damage. It's very difficult with the current ultrasound techniques to know accurately which are the boundaries of the treatment. And for HIFU, sometimes we have the opportunity to read about these techniques. We performed a well-controlled study and we published recently in 2020 a multi-center study. Well, certainly this technique is intriguing, quite interesting on a technological basis, but at the moment, for reasons that we can touch subsequently, if you like, is not comparable to the other treatment. Of course, thermoablation should not be the first-line treatment for autonomously functioning nodules, but as I told you, we now have a larger portfolio of opportunities. And so it could be considered in selected categories. For instance, laser in pregnant women, if of course they need a treatment during pregnancy, or for young patients with the small autonomously functioning nodules, and last, for those patients who are not candidate for radioiodine. And let's speak about the future. We know that we have now a strong trend toward the use of, I would say active surveillance, but we know that active surveillance several times is not appreciated by people. And so surgery is the only approach. But I would say that we should consider strongly the use of thermoablation as an alternative to active surveillance, because the results that we have are quite encouraging. We have already 3 well-conducted systematic review and meta-analysis in a large number of patients, and we can see that the efficacy was very high, but the complication rate again was minimal with laser and greater with the other techniques. And still, this is the demonstration of the opportunity of inducing a geometrical, a well-predictable area of damage in a metastatic lymph node of the neck. This was the feasibility study that we produced in 2013. And of course, for patients with a previous surgical dissection, this kind of treatment is by far to be preferred when we have small cervical lesions. And these are several papers that followed. I want just to show this paper from the group of the European Oncology Institute. You can see we have no uptake after treatment with a fluorodeoxyglucose PET scan. And I just cite this recent paper from our group because it's the treatment of cervical metastasis from medullary cancer. This was a patient that had already 2 dissection of the lateral neck. She had 2 metastases again, and in this way, we were able to demonstrate with the drop of calcitonin in the serum that is still undetectable, that the technique is extremely effective. Last, just one comment on a problem that is not frequently considered, that is bone metastasis. You can see here the PET-CT scan, an extraordinary result, also for pain control with the use of laser combined with the other treatment modalities. And so we should consider the use of laser ablation for those patients that are at surgical risk or are unwilling to undergo surgery or active surveillance, and consider laser as a possible option alternative to neck dissection in patients who are radioiodine refractory. Of course, we have several factors that favoring LTA, and last, it's most important, we have a few patients that have a use of opioids because they have an intractable metastatic lesion, and this is a very selective but very important use. You can see the two of us in the early 1990s. I worked with Claudio. He was an interventional radiologist of our hospital since the late 80s. First on the suspicious features of ultrasound examination of thyroid nodules, and then step by step on ethanol, laser, and all the other techniques. And unfortunately, Claudio passed prematurely last year. Many thanks for your attention.
Thank you so much, Enrico, for the presentation. Well, you said that laser ablation is very interesting and promising for this future aspect of the treatment. In other words, for the PTMC as an alternative PTMC. In other words, in terms of ultrasound and anatomical nodules features, what's the ideal patient for this treatment?
Many thanks, Stefano. That is a very useful question. Well, of course, we are just at the beginning of the trip, but what we know from literature and from personal experience is that patients with incidental micropapillary cancer, when are followed up along the years, frequently for some kind of treatment. I would say that, of course, we are speaking to the United States physician, and we know that the American Thyroid Association do not consider fine needle aspiration for lesions that are under 10 millimeter. But in Europe, when we have ultrasound features that are clearly, strongly in favor of a small papillary cancer, we use, if the lesion is over 5 milliliter, to perform fine needle and to operate or destroy the lesion. Well, I will say that the ideal candidate is a patient that has a centrally located lesion that is with a small distance from the capsule or the trachea. And of course, we would be able to treat without major problems also subcapsular lesions. But anyway, especially those lesions that are close to the trachea wall or are very posterior are at risk of complications. And so in these cases, probably surgery is still the best approach.
Let me comment on that. I think that we are starting to consider this more and more as an option for the papillary microcarcinomas. And the ones that you would consider for active surveillance are the ideal candidates to consider for thermal ablation. Those patients, as you just mentioned, Enrico, oftentimes, if the only option is surgery, then active surveillance may sound like a good idea. But if you give them an option, more often than not, especially here in the United States, the specter of cancer, they want to do something. They want to act. And so this directed interventional therapy, ablative therapy, is going to be ideal. And maybe because the ATA said, well, if we only have surgery as an option, and in the United States, we don't have a lot of centers. We have a lot of thyroid surgery being done by inexperienced surgeons. This is the way the country is so big and the system is set up that more people are getting hurt by surgery than helped with a small cancer. But maybe if we had this new technique and we could use it, it may be prudent to go ahead and biopsy and prove that it's cancer. And then there's value to the patient, value to the health system to intervene early, and psychosocially for the family and the patient, et cetera. So this is a great discussion. And I thank you for sharing your wonderful presentation. I have a zillion questions, but I know we have to keep on time. So I will probably bother you in emails later, but we will try to cover as much as we can. So go ahead, Stefano, please continue.
Thank you, Ralph. I have just one question from the audience for Enrico. The colleague says that when can we expect European guidelines regarding ablation technique in PTMC? In Asia, it seems to be widely accepted method. Can you say something about this?
Yes, of course. Well, but you see, in Asia, there are different approaches, and very well known as Sargent, that in Asia, we have a rather aggressive and complicated methodologies of surgical thyroidectomy, just because most of Asian women don't like to have scars on the neck. And so this is fantastic for them. They can destroy completely a small cancer without any residual damage to their beauty. As you know, all the geishas are completely covered, but their neck is well exposed. And so this demonstrates this is important. And you'll have an explosion of requests when you will start with this kind of treatment. And I would like to, confirm one consideration that Stefano told us before. With the laser, is extremely difficult to induce damage unless you are quite inexperienced. And the use of a 21 gauge needle is perfect for the treatment of neoplastic lesion in the neck.
I completely agree with your comments, Enrico, and I thank you very much And I think now it's the time to introduce the next speaker, Dr. Augustine Andrade. If you can connect, please, Dr. Andrade. Augustine is the chief of the division of the endocrine department, Mount Sinai Medical Center, is the director of the Thyroid, Parathyroid, and Pituitary Center, and president of Miami Endocrine Association. Please, Augustine, you can start with your presentation.
Good morning, everyone. Let me just, good morning, everyone, and buon pomeriggio in Italy. It's a pleasure to with a ModiLite laser using the Echolaser Smart. So what I want to do is before we start, I want to walk through the history of what we have available in the United States, some problems, and what can we offer to the patients, and then we'll talk about the Can you see my presentation? Oh.
Augustine, full screen, just hit presentation, the screen on the bottom. Because right now we just see your slides.
Okay. Wait.
Come down to the icon here. Yes, over more. Keep going to the right. Next one. No, to the right, to your right. No.
This one.
No, higher. And one over more.
This one?
Yes, please.
Can you see it now?
Yes, excellent.
Okay, perfect. Thank you. So what I want to do is to walk through what we have available in the United States, and then the introduction of this new methodology, which is the laser. So I want to start with this typical graph of Massa-Ferry, where we have the prevalence of the thyroid nodule. And you can see that is a linear relationship between the age of the patient and the prevalence. If you're 30, more or less 20% of the patient, they may have thyroid nodular disease, versus if you're 80-year-old, there is a 50, 60% that you have thyroid nodular disease. Now, we're lucky that about 5 to 10% of all these nodules are malignant. And therefore, we don't have to treat the majority of these patients if they are benign, with some exceptions. So these are the indications for treatment of benign thyroid nodular disease. If you have neck pain, dysphagia, dysphonia, shortness of breath with stridor, so long that you have a rule out cardiopulmonary and GI problems. Also static discomfort, toxic nodules, and nodules that are more than 4 centimeters. So what are the options for treatment that we have? So in the past, we used to use the levothyroxine, and now we know that because of the adverse effects of the medication, we don't use it anymore because of the osteoporosis and the atrial fibrillation. So we have the IDA-131 treatment, surgery, percutaneous ethanol injections for cystic nodules, the radiofrequency ablations, the laser, and what Dr. Enrico already discussed, the HIFU, that is not approved for benign thyroid nodular disease in the United States. And besides, the device is very expensive. And the microwave, that also is not approved in the United States. So we're going to start what we have been doing for so many years, the surgery. So there is 150,000 thyroidectomies that are performed in the United States each year. 3.4% are due to grave disease, benign nodules 63%, and malignant 33%. So about 94,500 patients, they have surgery for benign nodules that represent $2.1 billion per year that is the cause of surgery for benign nodular disease in the United States. So the other option that we have is to give iodine 131. This is a study of 96 patients given 100 grays for the multinodular goiter. And you can see that there is a 22% decrease in the volume in 6 months versus 44% decrease in the volume in 3 years. But if you inject the Thyrogen, in 3 years, you have a 41%, which is more or less similar to placebo. Whereas if you inject 0.03 milligrams of the Thyrogen, which is a modified release substance, then you have a 53% reduction of the multinodular goiter within 3 years. But over here, you can see that when you give Thyrogen, you have an increase in the chances to develop hypothyroidism, hyperthyroidism, and neck pain. So the percutaneous ethanol injections for cystic lesions is not used very frequently in the United States, but is very efficacious, and we have been used in Italy for more than 20 years. This is a case that was referred to us by the surgical department of a patient that had a very large nodule that was cystic. So we remove 109 cc's of chocolate fluid, and we put that 3 cc's of alcohol within the cyst. And this is 2 months later, and this is 7 months later. So remember, the volume was 128 milliliters, and at the end, it was 7.7 milliliters. And the cost of this procedure is $178. That's what Medicare pays for this procedure. What we have a study that we're about to present it to one of the journals. So we got 20 patients that fell to the aspiration of the cyst, and we injected with alcohol. We have an average reduction in 1 year of 70%. So what else could we offer to solid benign thyroid nodular disease? Well, we have the percutaneous ablation. We can use RFA, or we can use the percutaneous laser ablation with a ModiLite laser using the Echolaser Smart. So over here, you already saw in the previous presentations, you have 2 fiber optics that are separated by 1 centimeter. And we can provide 500 joules per ml. And the duration of this a procedure is about 10 to 20 minutes, average. So this is our first case. This is a 38-year-old female with 5-year history of thyroid nodule associated with a pressure sensation in the neck and aesthetical discomfort. Patient already had 5 needle aspirations that they were benign, and she declined surgery. So this case was referred to us for the University of Miami. This is the lady. We already introduced over here the 21 gauge needle, and through that needle, we introduced the fiber optic. You can see the Echolaser over here, the needle. This is my ultrasound machine. And so we deliver to the patient 3,606 joules. And what we have is that it decreased the size of the nodule from 22 milliliters cubic to 12.4 within 3 months. So this was the patient before the ablation. You can see the nodule go until the opposite sternocleidomastoid. You cannot see the trachea. And this is now. Sternocleidomastoid is clean, and the patient does not have more symptoms anymore. My second case is a 79-year-old patient that had 20-year history of thyroid nodular disease. Now she's complaining of dysphagia with a normal EGD. Patient have several FNAs that were normal, the normal TSH. And so this is the ultrasound prior to the procedure. And this is the ultrasound after the procedure. On this patient, we gave a 1,895 joules. And the patient dysphagia disappeared within 3 months after the procedure. My third case is a 22-year-old female that was recently discovered to have a thyroid nodular disease with a low TSH. She had no a TSI and no TBII, so it's not a grave disease. There's no stigmata of hyperthyroidism and no symptoms of pressure in the neck. The patient wishes to get pregnant and she declines surgery or IDA-131 treatment. So this is the scan showing the nodule, a toxic nodule in the right side, and the 23-hour uptake that is 33%. So over here, this is the Echo Laser Smart. You can see the way that we introduce the needle. Over here, where you see the needle track, we choose the number 3. So 1, 2, 3 is the third line. We introduce the catheter through that. It's very easy. You can see the catheter over here, and you can see the fiber over here, and it's ablating. So we start the ablation with 5 watts, and then like a 1 minute after you start with 5 watts, we lower to 3 watts. This over here is the parallel lines, and the circle is, you have to press over here so we can see the area that we want to burn. So this is prior to the treatment, and this is after the treatment. This is the TSH. You can see that right in December 2019, the TSH was 0.01, and in July 2020 was 0.8 after the treatment. So there's a study for Simonetta that show the pathology of after the laser ablation. And you can see over here that there is a lot of debris and a fibrous tissue. And this fiber, you still can see some normal cells that are surrounded by fibrous tissue. This study already was presented 10 minutes ago by Dr. Papini, just to show you that there's a 60% average of volume reduction with a nodule, and the rate of regrowth, meaning that there's a more than increase in the volume by 20% of the smallest dimension in 3 years is very slow. This is the data from all my patients. Over here at the bottom, you can see the size of the nodules, okay, and the reduction, okay. All are in 6 months except this in the bottom. The patient doesn't live in the United States, so we did it 3 months later. The important thing in this is that there was disappearance of symptoms in the 2 large nodules, and in the toxic nodule, there was normalization of TSH, keeping in mind that the patient never have any symptoms. As far as the adverse effects that we have on this, I took the liberty to put this study for late Dr. Pacella, and this is what he had. He had 0.5% of changes in the voice that was transient, hematoma 0.5, mild pain 3.3%, and a 1.6% that the patient had moderate pain that disappeared 1 or 2 days after the procedure. Severe pain was present in 0.2%, vasovagal was a 0.7, and cough 1 patient. So I put the same adverse effects on the same slide with my cases. We have only 3 cases, obviously, but I only have 1 patient that have mild pain. 2 patients have also mild pain during the operation. And I didn't have any other side effects during this procedure. So what is the difference between the ModiLite and surgery? ModiLite have the local anesthesia versus general anesthesia, the scar versus no scar, outpatient procedure versus a 1 day or 2 days in the hospital, minimal pain afterwards versus pain after surgery, the hypothyroidism. Over here, I put that 50% with a hemithyroidectomy versus 100% total thyroidectomy. Low parathyroid, 1.5 versus 8.3 in total thyroidectomy. No cases of permanent laryngeal nerve damage. And I put over here the partial thyroidectomy versus total thyroidectomy, 1.5 and 3.4% around. These were my reference. And the price that I am not going to talk about that, but definitely there's a different price. Recurrence rate, there is a 5% increase in the size of 20% within 3 years, and different studies depending on the time that you observe the patient. You can have a recurrence of 23% versus 0.03 if you have a total thyroidectomy. So my conclusion is that laser ablation is an outpatient treatment with an aim to reduce the volume by 50% in 12 months, which that is aimed for patients that have difficulty swallowing or neck discomfort. In our limited experience, we have 50% reduction in that in one of the 3 cases. I have almost significant reduction in one patient, but the patient is coming back next month. But we have a 45% decrease in the size within 3 months. Also, in our limited experience, this is what I learned. I learned that the technique is very easy to be applied by any physician that is capable to do ultrasound-guided fine needle aspiration. It's not expensive. In my office, it took me like 20, 45 minutes to do the procedure. The patient experienced minimal or no complications. In comparison to radiofrequency ablation that I performed too, I see when I teach the procedure, you need much less training to do the laser treatment in comparison to the radiofrequency ablation. And the weakness of this presentation is that the small numbers of patients that I have, but also since these were the first cases that I used, I opted to be very conservative in the joules that I delivered to the nodule. So instead of delivering between the 6,000 joules and more, I just gave half of what the patient was requiring. And even with that, we have a lot of success. All the patients have a diminish on the size of the nodules, and all the patient's symptoms disappeared completely. And one patient, the TSH normalized and was able to get pregnant. So without further ado, this is my humble hospital where I had to sacrifice and come to work every day. So this is the end of my presentation. Let me.
Thank you, Augustine. Thank you for your presentation. And yes, you're right. You have only 3 cases, but probably Ralph will agree with me. You can name officially named as the pioneer of laser ablation in the United States of America after this webinar. Do you agree, Ralph?
Yes, I absolutely think so. This is something that, of course, there's very little experience with in the United States, and we continue to need to investigate and compare the different techniques. I think I would put a charge to the companies, the technology, that eventually we want to make this as simple as possible and to be rendered to as many patients as possible. And I believe the technology can evolve to the point where it becomes as simple as you even just introduce the needle you have this computer software algorithm. It interprets the echo texture and the composition of the tissue, and it programs, and you automatically there, and it does
correct.
everything for you. You just sit back.
And exactly, that is exactly what happened. I was talking to the patient, chatting about the football game, and with the patient, and it was amazing. It's not the same experience that what we have with the radiofrequency ablation, that is more intense in all the sense.
Right, and this is why it should be simple. It should be available to everybody, and it should be easy as pushing a button, right? We love to have the expertise. We love to be the only ones who can do a thing or two. And this is something that I think the technology will continue to evolve, and we will get to a very automated process in the near future. But thank you for your presentation. It's wonderful.
No,
and I look forward to seeing you and meeting you in person soon.
Likewise.
Just one thing to add these comments. Thank you for the last sentence in your presentation, Augustine, because you pointed the attention on the delivery of energy. That means great safety of this technique towards the other thermoablative treatments. It's a very important issue to focus. I have also a question from the audience. Can you answer, Augustine, in your limited experience, but you can give us an answer. Is there a volume of the lesions that we are not able to treat with the laser therapy? What's your opinion?
Okay, so well, there's when I finish my treatment, I look at the echogenicity of the nodules, and when I finish the treatment, I see that the nodule is very hypoechoic, which show that there's an area of necrosis. And that then at the end of that, I put a Doppler, and the Doppler, all the vascularity that you were having in the nodule disappear after the laser. So I'm sure that there's going to be part of the nodule that is not going to be ablated. But for what I've seen, if we deliver the right amount of energy, I think that I'm not going to say it 100%, but a good 80% of the nodule is going to be ablated successfully. I don't know if that answered the question.
Yes, if I could add a comment, we don't have a maximum volume because we can return with one more session, with multiple sessions to reduce the volume of the nodule. So we can have more session and with the multiple insertion of needles in the nodule. If there are not other comments or questions, I think that Ralph can introduce the next speakers.
Great, Stefano, thank you. Yeah, well, it is my pleasure to introduce the next two speakers because they have been very instrumental in these efforts in the United States to push thermal ablation technologies forward. And what we have done very early on is to think about having a very multidisciplinary and inclusive group of experts that can come together and hopefully forge the path forward for these techniques to become widely adopted for the benefit of our patients here in the US. So Tim Huber is on, and he is an assistant professor of interventional radiology at Oregon Health Sciences University. And Catherine Sinclair, who I've known for a very long time now, is an associate professor of otolaryngology, head and neck surgery at the Mount Sinai School of Medicine. And they have been very, very influential and helpful in pushing thermal ablation techniques forward, and especially with consideration of RFA and how we will use it in the United States, and hopefully how we will get all these stakeholders involved in these decision-making processes to see the value of such an intervention. So I think both Catherine and Tim are going to present some cases to the group for discussion, and I'm looking forward to that. Thank you both, and you guys can decide as to how you want to handle this, but I'll leave it to you to go ahead. You may have a case each or so, but you guys got it. Your floor.
Tim, do you want to go? Do you want me to go first? I think your case might be a little more complex. Sure, if you want to go first, that's fine.
Okay. So I wanted to thank Professor Spiezia and Professor Tufano for inviting me to participate today. It really is an exciting time in thyroidology with these new ablative, well, not new for the rest of the world, but new for the US ablative techniques. And it's very exciting to be a part of it. And I think it's been a big adjustment in thinking for many of us who have particularly, I think, that on the surgical side, who have begun using these ablative treatments and getting our minds around the fact that just completely getting rid of a nodule is not necessarily what's best for a patient and not always necessary for a patient. And what seems to be much more important is getting rid of that patient's symptoms. And I think adjusting our way of thinking from nodule elimination to nodule reduction with a focus on symptom score as much as volume reduction is a very important consideration with these techniques. And I agree with Professor Spiezia that it's not so much about nodule ablation techniques versus nodule ablation technique and which one's superior. It's much more about surgery versus nodule ablation. And it may well be, as more and more experience is gained with the particularly laser and radiofrequency ablation, that different ablation techniques are useful for, or more useful for, different types of disease processes or for different types of patients. And so perhaps some of those things still remain to be established. But I just prepared a very brief case really to sort of, sorry, I'll just go back, to think a little bit about complications and how to minimize complications, I guess, in when using ablative techniques. And I'm very interested, obviously, not having done laser ablation as yet, to hear from the experts here today about potentially complication risk and minimizing complications in laser ablation. So this was actually a patient that came to see me a couple of. Oh, my apologies. Let me just go back. I'll be 1 sec. Sorry about that. And 1 moment. Let's just press that button again. Let's see if this works this time. Is that better? There we are. Sorry about that. So yes, so this was a lady who came to see me a couple of months ago. She hasn't actually yet been treated, but I thought it brings up some interesting points. This is a 45-year-old lady. She's a singer, of course, which always in thyroid surgery and also ablation, it kind of raises your levels of worry a little bit with regards to the laryngeal nerves. She does have a history of a cervical spine procedure, entry from the right. She has a right neck scar, and apparently the levels that were fused were C5, 6. And she has a left-sided thyroid nodule with 2 prior benign biopsies. She has mild compressional symptoms when lying flat. So she has a symptom score. She sort of circles sort of 3 to 4 on the 1 to 10 scale. And she's had a volume increase in this nodule of about 20% in the past year. And she's worried about that because she really wants to prevent further growth. I think the volume increase was a little over 20% actually. Cosmetic score, not hugely significant, but there's definitely something to be felt. And TSH, normal, euthymic. So this is the nodule. It's not a huge nodule actually. And you can see left-sided, this is at the bottom of the left thyroid lobe, just sort of above the clavicle. And, interesting sort of orientation. And again, just in the craniocaudal view. And then this is the Doppler vascular sort of image. So a lot of vascularity, vascular flow in this nodule, with a lot of it sort of coming from that medial aspect near the trachea. So I'm really opening this up, particularly to our, expert of laser users here about, I think we're a little more familiar with radiofrequency, as I mentioned. What features of sort of this history ultrasound may make this patient a good candidate or not for particularly, for thermal ablative therapy in general, with sort of a specific focus on laser, and sort of, are there any features of the history that, warrant further preoperative investigation?
Catherine.
Yes.
I think that you and I have spoken a little bit about this and the concern that maybe when a nodule has a significant amount of vascularity or prominent vessels, the ability to ablate those. We definitely love to hear from Dr. Pepini, Professor Pepini, and Spezia and Augustine, of course, as to RFA versus laser and the ability to do that, because it seems like maybe in this situation where it's a very hypervascular nodule, even though euthyroid, you're still concerned that if you don't ablate those, you will have a recurrence or persistence of the problem. Would you agree that's a concern?
Okay, can I?
Catherine?
Yeah.
I would agree with this nodule, and I think also, you know, there's the fact she's had prior surgery, and there's, you know, and you know, there's definitely a need to sort of check the larynx and the vocal cords here as well. But definitely the vessels, I think Dr. Huber in a moment will present something a little bit looking at vascularity of nodules again. So, but yes, we can definitely, you know, particularly this nodule with medial feeding vessels and very much adjacent to the trachea. You know, it is a question, you know, do you think that not being able to sort of target them enough would lead to peripheral regrowth in this nodule?
Stefano?
Yeah, before giving the comment on this case, I would do this warning to the attendees, because there are a lot of questions that we cannot answer now, but we collect all the email of the attendees and then we'll reply later to them all. Well, thank you, Catherine, for your clinical case that I think it's very interesting and intriguing, because it's a particular a nodule with a particular shape. It's a flattened nodule, not unusual shape of
Yes.
the presentation of thyroid nodules. The transverse diameter is similar to the longitudinal diameter I see in your slides. Well, some comments on this case is that 5 milliliter probably is difficult to explain with the symptoms that the patients refer. But the medial aspect of the nodule is so deep and close to the esophagus, and probably the adherencies of the previous surgery could explain it. I don't know your opinion about this, but this could be an answer to this problem. I think that in this case, the procedure is not easy to perform for beginners. For both technique, PLA or RFA, if you would ensure the maximum volume of necrosis, because the deepest and medial tissue of the thyroid nodule should be undertreated by RFA due to the dangerous triangle, which is very, very close to the medial aspect of the nodule that's very deep. So in any case, we have about 1/3 of the nodule that cannot be treated by RFA in any case. By laser, we have two main advantages. Before all, the low deliver energy during the procedure, because I think that in this case, 5 milliliter, we need almost 25,000 joules to delivering during this procedure. With RFA, we have 2,500 or at least 3,000 joules to deliver. So we have, in this case, two chances. The first for beginner, I think. In other words, to put one fiber in the middle of the longitudinal axis, set the output at 3 watts to limit the safety blue line from the anterior and posterior capsule, giving 1,800 joule, we will have 2.5 milliliter of necrosis. That means half of the basal volume. This is not an autonomous function in thyroid nodule. So our target is to reduce, to shrink the nodule. Our goal is not to completely ablate the nodule. Or for advanced operator, skilled operator, we have a second choice. If I can share my presentation, is it possible to share my presentation? I ask the technician. You see my presentation?
Can I stop?
Okay. You see it now? Just a sec. Okay. Okay, the first choice is to introduce the fiber laser in the middle of the nodule and to have approximately this volume of necrosis that is the half of the node we have to shrink. The second opportunity is, but I have to conceal the previous. Okay. The second opportunity, if we consider that the nodule is about 20.6 centimeter, okay, so we ideally divide the nodule in 3 segments, okay, 1 centimeter, 1 centimeter, and 0.6, okay? And we put, firstly, the first fiber here, and then we remove the guide from the probe. So we have a transverse scan, but it is only for skilled operator. We have the transverse scan, and we introduce with the freehand technique the second fiber parallel to the first one with a distance from each other of 0.6, 0.8, 1 centimeter. We have this necrosis. It is larger than the previous one. So we have 2 choices: to put 1 fiber or have 2 sessions, because the beginner can insert the first fiber, complete the first session, and then insert the second fiber at a distance of 1 centimeter from the other, or put in the same session the 2 fibers into the thyroid tissue and have an enlarged volume of necrosis. What's your opinion, please?
And may I give a comment? My feeling is similar to that of Stefano. I suppose that it's quite difficult that the discomfort that the patient is suffering is due to this rather small nodule. Anyway, we have as personal experience and based on the literature, the certainty that a nodule that grows by 20% each year is going to grow during the following years. We have the nice study from Cosimo Durante, 1,500 cases, and we know that about 85–90% of the nodules don't grow or grow minimally over the years. But we know that nodules that start growing will go at a rather steady pace over the years. And here it's very important to consider an aspect. That is, until now we had the nodules that were small and stable, and the nodules that were, well, heavily symptomatic. And for those nodules, it was useful to perform surgery, and for the other, nothing. Now, we must have some kind of window where the nodules that are not huge but keep growing over time should be placed. And this is the way to approach the problem. That is, in other words, if you have a small nodule that is stable, 90% of the cases, you just dismiss the patient. I'll see you by 5 years. If you have a nodule that is 100 or 100 cubic centimeters, milliliters, you will tell the patient, my friend, you are safe, you are young, you have a very low risk, and so I will remove your nodule surgically, or otherwise you are at surgical risk, or you don't want to undergo surgery, I will treat you with a thermal ablation for palliation. But what is most interesting is that when we have nodules that keep growing, and well, I will say they become symptomatic, the patient start having cosmetic concern or that subtle discomfort when she lies down or in a particular position, well, in that case, you should monitor the patient, and if the nodule keeps growing, maybe by 1 year, at that moment, you have to perform treatment because you don't need any heroic capacity, but you have a substantial decrease because the volume of tissue to be ablated is not so large. And so I understand that this is difficult to be said. And for instance, to place cutoffs is totally, well, individual. But I would say that when a nodule is 2 centimeters in largest diameter, I would speak in diameter because sometimes it's easier, and then it's 3 centimeters, and then it's 4 centimeters. At that time, you have to treat with a laser. Because if you don't do this, the patient will become surgical. And about the decrease in volume is important, but certainly at the beginning, please don't aim at a near total destruction of the nodule. Because when you are not expert, this could be a good way to induce damage and to stop using the procedure. And so you explain to the patient that you will induce a substantial decrease and the disappearance of symptoms. And after a few treatments, when you are more experienced, step by step, you will try to get greater reduction and more conclusive treatments. But remember, it's now clear that the decrease at 6 months is strongly predictive of the final result. And there is no problem in performing the second treatment at 6 months and completely or nearly completely destroy the residual vital area. Sorry, I speak too much.
No, so Enrico, what you're saying is very important and to the point. The first is to set the realistic expectations for yourself and for the patient. So you agree on what you're trying to achieve, what you expect to achieve. The second, we are currently wrestling with the next iteration of the ATA guidelines. And one of the key things that you just discussed, I mean, we need to write all this down, is that there are differences between the benign nodules. And of course, with Cosimo's paper, about 15% grow. They will continue. We will lose the window of opportunity if we dismiss this to just observing, and then we wait for surgery. These are different than those that are stable, and we need to intervene. That is the time for thermal ablation. So we're trying to capture this essence. But thank you for that summary. It's wonderful. And Catherine has a lot of experience in this area, and it's great to bring these things up because it's hard to provide this perspective. Of course, we don't think this patient's symptoms are certainly derived only from this. So this is a really delicate discussion. And in the United States, our patients don't listen to us so well. They want to know everything, and we spend a lot of time talking to them. And so it's a very good discussion.
Thank you. It's fantastic, very eloquently put. And I think we decided with this patient to review again in about 6 months and see if there's been ongoing growth. But thank you very, very much.
Thanks, Catherine. It's wonderful. Yeah. Tim, would you like to go?
Yep. Let me just get my screen shared here. There we go. All right. Thank you, Ralph, and thank you, Stefano, for putting this together. This has been a fantastic discussion, really great session. I'm going to hopefully add a little bit to what Catherine brought up with hypervascular nodules with this case presentation. This is a case from our early experience here out in Oregon. So I saw a 25-year-old female a few months ago. She'd had 3 years of anxiety, hair loss, and palpitations, and discovered a nodule on the right side about 2 years ago on palpation. More recently, she had started to develop a globus sensation and pressure in her neck, and was seen by her outside endocrinologist, did an ultrasound, found a nodule, and suppressed TSH, and sent her into our thyroid and parathyroid clinic. When she was referred in, her TSH was quite low, free T4 is normal. She has an ultrasound on the initial workup that showed basically a 5 cc nodule on the right lobe. And it was quite hypervascular, a lot of blood flow around the nodule and within the nodule as well. The uptake scan shows about 42% at 24 hours. She had a biopsy done by her endocrinologist on the outside before referral, and then also by the endocrinologist who saw her when she came to Oregon. Not our standard for 2 FNAs on these patients, but that's how she ended up coming to us. So we discussed options. She very much wanted to avoid radioactive iodine. She was a single mother. Couldn't take time off of work and couldn't isolate from her child. Also, around the time COVID was happening and being away from home and in a hotel was not an option. And surgery was also sort of out of the question for her due to sort of all the social circumstances at the time. So we felt this was the best option for her. So pre-procedure, we scan the nodule again just to get a lay of the land before we start the procedure. Again, you can see the nodule is quite adjacent to the carotid there. You can see the danger triangle here medially. And you can see on the color flow, we have a fair amount of peritumoral vascularity, several large vessels kind of coursing around the edge of the nodule. Nodule also kind of protrudes anteriorly up toward the strap muscle there. So for this patient, we did a lot of hydrodissection to try to push a little bit of a plane between the carotid and the nodule, as well as to hydrodissect anteriorly along the nodule to give us a little bit of a thermal barrier. We then proceeded to ablate the nodule kind of in the standard RFA fashion with moving shot technique and transismic techniques. I spent extra time trying to ablate the peritumoral vessels as well as I could see them. And we'll talk about that on follow-up. So 1 month, the gland looks preserved, but we see the nodule itself is diffusely heterogeneous. It's reduced in size somewhat, 3.7 cc's, about 30% smaller. And her TSH is up somewhat, not totally normalized, but improved. And what's interesting in this patient, you can see again where some of these peritumoral vessels were before that we didn't really see on our post scan. They've sort of recanalized, and you can see the adjacent, what looks like viable nodule adjacent to some of these vessels along the periphery here. And that becomes even more apparent on the 3-month follow-up, where the nodule continued to shrink in size. Now we're at 50%. TSH did improve and actually normalized, and her symptoms improved, her palpitations and her anxiety had improved. She still had some hair thinning, but overall was improving. But you can still see a few areas of residual tissue along the margins here and the corresponding vascularity to these areas. So hypervascular nodules can be kind of difficult to treat. They present some unique challenges. We started talking about a little bit earlier. Sort of 2 issues that come up are heat sink effect and perfusion-mediated tissue cooling. These are things that we see in tumors and other organs, the kidney, the liver as well. In the liver, especially, we see that the portal veins can carry relatively cool blood in and carry heat away from the area you're trying to treat, and can actually kind of be insulating and can affect the shape of your ablation zone and can cause under treatment adjacent to the vessels. Perfusion-mediated cooling is a little bit different. It's sort of like a radiator effect. If you have loss of capillary beds and just generally hypervascular tissue, you can take more energy deposition to thrombose, stop the flow, and then eventually cause the destruction and necrosis in the tissue. Theory is that it requires a bit more energy deposition to actually treat those really hypervascular tissues due to that effect. Liu et al. Did some studies in porcine models looking at this heat sink effect. This was all done in liver, pig liver, and examined for RFA. They found that vessels that were basically less than 2 millimeters and under, all exhibited thrombosis in their histology. Those over 6, none thrombosed, and in between there was sort of a gradation. And so what they took from this was that the very small vessels thrombose very quickly during RFA. Larger vessels have this heat sink effect where they're taking away the heat and kind of protecting themselves and the adjacent tissue. Now in the liver, they found sort of this break point where 2 millimeters, they thrombosed, over 6, they didn't. That probably doesn't hold in the thyroid gland, but it's an interesting concept and it sort of highlights that effect of RFA in the liver. So it's really important to do a careful assessment of the peritumoral vessels and have an understanding of how vascular your tumor is and where you may need to spend some extra time treating and depositing energy. And you can use special techniques trying to actually target that with RFA to try to treat those vessels and get a little bit of a better result. I wonder with laser, how you guys deal with hypervascular nodules, hypervascular tissue. Do you do anything different or special to try to treat sort of large peritumoral vessels? Or do you trust that the settings and the guide will give you an adequate ablation?
Stefano, Augustine, and Professor Papini. Would you care to comment?
Going to the first case very shortly, to put the laser instead of the 2 fibers vertically, to put it horizontally is something that can achieve significant reduction in the first nodule. But when the nodule is very vascular, I only have one case that was very vascular, and I used the radiofrequency ablation, and it was very successful without any problem. And now I have to say I used both techniques, the radiofrequency ablation and the laser. My temptation in the first case was to use the radiofrequency ablation because it's very versatile and I can go wherever I want with my radiofrequency ablation. But to answer the question of the vascularity, I haven't had any problem using laser with vascular lesions. But again, I only have 3 cases, so I'm not an authority to say anything more profound than that.
Well, if I may comment, this time I must change something about the general rule I talked to our dear Catherine. And well, of course, the treatment of hyperfunctioning nodules is a special area because besides the high vascularization and the sink effect due to this strong blood supply, we have a tissue that has a marked growing tendency. That is, in most cases, if you don't destroy nearly completely the lesion, by 5 years, you are going to a relapse of hyperthyroidism. And so this is the reason why we suggested a cutoff for the preferential treatment of hyperfunctioning nodules, because you should destroy nearly completely the lesion. Otherwise, you induce in specific moments a rather successful effect, but in the medium term, that is by 2, 3, 5 years, you will have a relapse. And of course,
Enrico,
yes.
I'm sorry to interrupt, but that limit is 15 milliliters for the audience and what was your information on that before?
Yes, it's 15 milliliters on the basis of data from an ongoing Italian study, multicenter study, that is completed, and we have processed the data, and it's going to be submitted. And it is demonstrated that under 15 milliliter, we have an elevated level of efficacy, but over. Because we must speak of the real world, not of the trials. And in the trials, you do your best. And of course, this is an artificial area.
Mhm.
But in everyday practice, what you were talking about, Ralph, that is the common endocrinologist, the common surgeon, the person who did not devote all his life to just these techniques. For the common person, you must rely on the results of real life. And the results of real life is that you can attain nearly whatever you want, but at what cost, with what risk, and based on what experience. And so this could be misleading. We must state that, if needed, like in the beautiful case of TEAM, of course, this is quite effective.
This has to be the discussion. And I appreciate what you said about Stefano, because sometimes these patients may want a quick fix. The autonomously functioning thyroid nodule may not want radioactive iodine. The patient is younger, they might not even want a chance for this to happen again in the future. You have your perspective. Maybe surgery is the best. Let's not say surgery is always so bad, but maybe then we feel that as we communicate, we start to define the best treatment path. And then even with surgery, I have to just give a shout, because we seem to be this, hammering surgery a little bit. Stefano does robotic surgery. We have pioneered and popularized transoral surgery to avoid the scar that still may have some value to patients. So these communications, us all coming together to know what we can offer for the patient, we leave the decision to them, because we explain all of the options realistically, as you just beautifully said. So, your wisdom is right on, as always. So thank you for explaining all this to us.
It's the wisdom of gray hairs.
Yeah.
Unfortunately.
Yeah.
Thanks, Ralph, because this is the goal of this webinar, to discuss with the colleagues, to show the possibility, the chances we have with this modality of treatments. But finally, let me give some comments and a question to Tim, just to give the right messages to the audience. The question is, the patient was given a antithyroid medication before the treatment or not?
She was not. She's not been started on antithyroid medication yet.
Okay, because I see that the TSH was quite suppressed.
Mm-hmm.
The message is very important. I ask also to Papini and Augustine, the message is very important to give antithyroid medication before, because this reduces the hypervascularity of the nodule. It's the same we try to reach before to have surgery, because for surgery it's important to reduce vascularity during the operation, first of all. And the comments, the patient arrived to you with the 2-5 needle aspiration cytology, but according to the guidelines, that we don't need cytology for, also because in some cases, it could be it could become complex for the diagnosis by the cytologist, because it's easy to go versus Ty 3 or Ty 4 for the follicular organization of the cells in the specimen. So this could be understood as a problem during cytology. And a comment, a second question: how many joules were delivered during this procedure?
Great question. So we didn't have the ability to record the joules that were being delivered at that point. We have subsequently gotten technology to do that, and we're starting to record that now. But at this time, we didn't document that.
Okay, no problem. Because I think that considering the basal volume of the nodule, a large amount of energy is needed to destroy, to ablate the nodule. I think that this volume is ideal to treat as an autonomous function in thyroid nodules. The nodule is very superficial, so it's very close to the capsule. Did you use hydrodissection or by lidocaine or with
yeah, we used lidocaine hydrodissection anteriorly, kind of like you showed in your cases.
Okay, with this answer, I reply also to an answer of the audience that asked us if we have problems with surgery after thermal ablation. If thermal ablation is done in respect with the protocols, we don't have adherencies between the capsule and the step muscle. I personally operate some patients after thermal ablation. I see the RAF agree with me, and I had no problem if the operator is very skilled with this technique and they apply the protocol, accurately apply the protocol. The second comment is laser is relatively tissue independent, so it's not so the hypervascularity does not affect the results and the efficacy of the laser technique. For RFA, you know that sink effect is an important issue during this procedure, that for the thyroid nodules can be in this case, we can use a different technique, the vascular RFA. You know, we have recently published on Frontiers in Endocrinology online our paper on the use of this technique, our personal experience. Because if you firstly necrotize the afferent vessels, and at the end of the procedure, the venous vessel, you reduce in a very important way the vascularity of the nodule, so you improve the results of the necrosis. But you deliver an amount of energy very, very, very great that is not it's not good for a very small nodule and in a superficial aspect of the neck, like in this case. So I think that in this case, probably you have delivered about 25,000 joule, while with laser, we at least could use 2,500 or 3,000 joules, because according to the volume and to the delivery of the energy that we need, this is the amount of the energy. So I think that both techniques are very, very, very useful as minimally invasive treatments. We need very skilled operator because both techniques can be used, but the most important thing is who use this technique, how is skilled, what are the expectative of the patient and of the surgeon, of the interventional radiologist or the endocrinologist. So this matter is very, very important to consider for these techniques. I have no other question or comments, and I thanks Tim for this interesting clinical case. And I think that we have demonstrated that both techniques are important. There are pros and cons. One is more operator dependent, and it's linked to a mental, how can I say, attitude of the operator, because there is a lot of improvisation during RFA procedure, because I have to divide in so small entities the nodule to produce a lot of spot of necrosis. With laser, I put my hand on the neck of the patient, and so a not so skilled operator can perform a good technique and have a good success after the procedure.
Thank you very much.
You're welcome.
Stefano, I think this was wonderful. I'm so happy that you introduced this idea to us and the participants and the team, and that we were able to do this together. I really have enjoyed our time this morning here for us in the morning in the United States. I know Catherine may be in Australia, and so she's joining us maybe at a very odd hour, I don't know. But it is wonderful to have everybody here to discuss this, and I can't tell you how much we appreciate your contributions. Enrico, as always, Augustine, thank you so much, Tim and Catherine. This is wonderful, and I hope our participants who joined us really learned a ton. I learned a ton, and it's very infrequent nowadays that I can go to anything and say I learned that much. So wonderful experience. Thank you all.
Many thanks to the organizers and to the wonderful speakers. And as always, we also learned a lot.
Thank you to everybody, and see you again. I hope to, as soon as possible, travel to the United States, meet you in person, and to try a group of starting this procedure in the United States. Thank you. Thank you to you.
Thank you all.
And for your contribution.
Have a good weekend.
Bye.
And see you soon. Bye.
Bye.